Hi, okay, why don't we go ahead and get started? Hello, everyone, and welcome. My name is Dr. Heather White. I'm the Executive Director for Together for Health. I'm very pleased to welcome you to Together's ongoing webinar series, which highlights numerous topics in global cervical cancer prevention and control. Today's webinar will focus on the findings of the MULHER study, which was to evaluate new diagnostic technologies and service integration of family planning and cervical cancer services, along with national partners in Mozambique, a country with exceedingly high cervical cancer burden. Before we begin, just a few housekeeping notes. Note that all attendees are on mute, and following the presentation, we will have roughly 15 or 20 minutes of questions and answers. If you have a question for the presenters, please go ahead and write the question in the chat box, and we will do our best to get to all of the questions. Feel free to use the chat box throughout the presentation period, as we'll try to answer as many questions as we can during the presentations, and then as we transition to the Q&A portion. The webinar is being recorded and will be available on our website after the event. You can find it at togetherforhealth.org. A copy will also be sent to everyone who registered for the event. If you're interested in learning more about this or similar topics, please let us know. At the end of the presentation, we will post links on how you can get on Together's mailing list and contact us directly with ideas or feedback about this or any other webinar topic. Okay, with that, why don't we get started? Next slide. Quickly, I would love to announce that just yesterday we kicked off our fall fundraising campaign called November, which supports our mission and efforts at Together for Health. And if you'd like to learn more, please use this link or go directly to our website. Okay, now we'll get started. Our first speaker today is Dr. Mila Pontremoli Salcedo, an assistant professor and director of training and education programs in the Department of Gynecologic Oncology and Reproductive Medicine at the University of Texas MD Anderson Cancer Center in Houston, Texas. Dr. Salcedo is the co-chair of pre-invasive program at the International Gynecologic Cancer Society and the International Affairs Advisor for Teaching and Research at Santa Casa Hospital in Porto Alegre, Brazil. She oversees multiple training programs. She oversees training programs in multiple countries across the global South and in underserved parts of Texas in the U.S. She is one of a team of clinicians from MD Anderson working as technical partners to the government of Mozambique on this study. In her presentation, Dr. Salcedo will provide an overview of the partnership and collaborations to date in Mozambique and MD Anderson's role to build capacity with government counterparts on cervical cancer prevention through service integration and development of improved technologies in diagnostics and pre-cancer treatment. Okay, thank you. Over to you, Dr. Mila.
Thank you so much. I really appreciate the invitation and would like to thank Dr. Heather White and the whole team for the invitation to present on behalf of our team, the MULHER study that we ran in Mozambique. It's an honor for us to be here. Thank you. Next slide, please. I have no conflict of interest. Next slide. And we'll talk a little bit about cervical cancer in Mozambique. Mozambique, as Heather said, is a sub-Saharan Portuguese-speaking country in Africa that has one of the highest burdens of cervical cancer in the world. And this is due in part to a lack of access to cervical cancer screening and also few medical providers skilled in the treatment of women with pre-invasive cervical disease. Next slide, please. We have a lot of challenges there in cancer for cervical cancer prevention, lack of infrastructure, lack of equipment and resources required for screening, lack of pathologists and pathology supplies. We have in country around 15 pathologists for the national system currently. Lack of human resources. There are just few providers skills in delivering diagnostic and therapeutic services for cervical cancer screening and treatment of women with the abnormal screening test. And for the patients, we have lack of access. We have lack of screening and treatment facilities there in Mozambique. Next slide, please. We'll talk a little bit about our collaborative research that we have been doing in the country. Next slide. And the first study, the first collaborative research project that MD Anderson did with Brazil and Mozambique was completed in 2020. We call the Capulana study, and this was a study with primary HPV testing for cervical cancer screening. We enrolled 898 women, and the HPV positivity rate was 23.7%. In this study, the HIV positivity rate was around 20%, and 39% in women living with HIV, it was the HPV positivity. So it was around 40% for women living with HIV, the HPV positivity, and 23.7% was the overall HPV positivity. And for this study, more than 90% of the HPV positive women completed all steps for their diagnostic, workup, and treatment. And the treatment for this study, the majority of the patients were treated with cryotherapy when they had, when they could do the ablation therapy, when they were eligible. And if not, they received LEAP as a treatment or other surgeries, and they were referred to the gynecology or gynecologic oncology at that time. And in this study, we worked a lot in capacity building. It was our first study in Mozambique, and we built capacity in research for the country. Next slide, please. And for the capacity building, we thank our collaborators from Brazil. They trained the research nurses, they trained the laboratory technicians, and they trained research personnel. They ran lectures, and they also ran practice in research with our colleagues from Mozambique. Next slide, please. And following up this study, then we started the MULHER study. It's a prospective trial of Mozambican women undergoing cervical cancer screening with HPV testing. And this study was in conjunction with Family Planning Services. It was funded by USAID and the National Academy of Science, and it was just published. Next slide, please. So for this study, it was an evaluation of innovative technologies and approaches to addressing cervical cancer and combined with family planning services. The idea was to scale up both services. So women were screened with HPV tests in Maputo City and Gaza provinces, Gaza province. And for this study, the patients could choose between self-collection and provider collection. We use as the main treatment thermoablation for if the patients were eligible for ablation, and if not, the patient were again follow up by the gynecologic team for the study or the gynecologic oncology team. The new technologies developed by Rice University Bioengineer Department, they are our collaborators for many years, and specifically in this study, we work with the point-of-care HPV test and also the optical imaging to diagnose precancer lesions. Next slide, please. To expand reach to both services, cervical cancer screening and voluntary family planning, we enrolled 9,014 women from January 2020 to January 2023. 97.5% of the women chose self-collection, and the HPV positivity rate was 31.1% overall and 39.5% among women living with HIV. Of the 2,805 HPV positive women, 92% of them returned for follow-up and treatment, including ablation, LEAP, and a cold knife conization. 31 women, so 1.2% of these patients were diagnosed with invasive cancer, 30 patients with cervical cancer and 1 patient with vulvar cancer, and they were all referred to gynecologic oncology. Next slide, please. So, and the women living with HIV in this study were more likely to test positive for HPV compared with the HIV negative women, and they were also likely to more likely to have cervical lesions ineligible for ablation. They were 13% compared with the 8% in the HIV negative women. Regarding the loss to follow-up, if the lesions were ineligible for ablation and these patients needed to be referred to the gynecology, 36.9% of the women living with HIV compared with 15% of the HIV negative women were referred to the gynecology. And in this step of the study, we lost 89 patients that they didn't come back. And from the 89 patients we lost here at this step, 75, so 84% were women living with HIV. Regarding the pathologic results, we only had pathologic results for 217 participants. And in these patients, if they received LEAP or cold knife conization of cervical biopsy, we had pathologic results. So 83 patients diagnosed with CN2-3, 70% of these patients were women living with HIV. And from the 31 patients diagnosed with invasive cancer, almost 60%, a little more than this, were women living with HIV. Next slide, please. To address many of these challenges that we had in this study, we are launching 2 more studies in Mozambique. The first one will be start enrolling patients hopefully January 2024. It's a randomized clinical trial to assess the effectiveness of thermoablation versus LEAP, loop electrosurgical excision procedure, for cervical cancer risk reduction in women living with HIV. And all these patients, they will have confirmed CN2-3 with pathologic diagnosis, and they will be follow-up in 6 and 12 months. This will provide more data on effectiveness of thermoablation among women living with HIV, as we don't have robust data right now about these patients. One more slide, please. This will be in partnership with CISPOC, the local NIH, and with Maputo Central Hospital. Next slide. The second study will be launching in 2024. It's the Avanço Research Consortium, a Mozambique, Brazil, Texas alliance to advance novel and affordable technologies for prevention and diagnosis of cervical cancer, again in women living with HIV. It will be a prospective study to evaluate barriers and facilitators to follow-up of care for women who are ineligible for ablation and need to be referred for the next step. We'll be studying the development of new technologies. In this study is the in vivo diagnosis for cervical cancer, for cervical dysplasia, and also a digital platform to provide histologic quality images of cervical biopsies and lip specimens to enable high-quality, rapid diagnostic for pathologic services in these areas. And this is in partnership with the UEM, the local university, and also Maputo Central Hospital in Brazil. Next slide, please. We also like to thank all our partners and collaborators. They are amazing, and we could not do this by ourselves. So we thank everybody that worked hard in this study. Next slide. And as final considerations related to HPV testing and treatment of pre-invasive disease, the cervical cancer screening with self-sampling HPV testing is feasible, even in low-resource settings. And we were able to achieve good rates for treatment, for all the follow-up and treatment, of course, with a lot of resources and a lot of and some challenges. But the development of new strategies and new technologies for low-cost point-of-care diagnostic and treatment will improve access for screening and treatment and reduce the burden of cervical disease towards the global elimination of cervical cancer. Next slide. We are sure that education, training, and capacity building, local capacity building, is key for all the studies and for the elimination of cervical cancer. Next slide. And we thank our Capulana and our MULHER study teams. We really thank everybody that worked hard in this study with us. Thank you.
Thank you, Dr. Salcedo. That was a great presentation. We appreciate it. And if you have any questions for Dr. Salcedo directly, please go ahead and put them in the chat box and we'll get to those. Our next speaker today is Mr. Marcos Chisano, Director of Evidence for Population Services International in Mozambique. Mr. Chisano is a highly trained research and M&E professional with more than 15 years of applied experience. In his role as Director of the Evidence Department at PSI Mozambique, he provides technical support in the design and implementation and monitoring and evaluation of projects for public health and health system strengthening initiatives, with expertise in mixed methods applications. In the MULHER study, Mr. Chisano led the design, data collection, and analysis for PSI Mozambique to formally evaluate the impact of service integration for cervical cancer screening and voluntary family planning in multiple health centers, and to identify promising integrated service delivery models to take forward. In today's talk, he will provide an overview of the study findings related directly to the integration of FP in cervical cancer services. Over to you, Marcos. Thank you.
Thank you, Heather. I would like to thank you on my behalf and everyone involved in this study for the opportunity to present these results. Next slide, please. So why integration and why cervical cancer screening and preventive therapy with family planning? So integration is a higher practice and has been examined through HIV, family planning, immunizations, antenatal, postnatal care, and family planning, but less for family planning with cervical cancer screening and preventive therapy. Little is known about the effect of integrating family planning with cervical cancer screening and preventive therapy. Next slide, please. So the goal of our overall MULHER study was to develop, implement, and test integrated cervical cancer screening and preventive therapy and voluntary family planning service delivery models as part of the peer project to evaluate whether integrated service delivered can optimize uptake and impact of both services. The study was conducted in 4 public health facilities in 2 provinces, as Mila mentioned, in Mozambique from January 2020 to January 2023. Woman aged 30 to 49 presenting for cervical cancer screening and preventive therapy services or family planning services were eligible to participate in line with WHO cervical cancer screening age guidance. Next slide, please. So this was a mixed method study under the whole MULHER study and used a combination of research and monitoring data. We have used monitoring data with 9,014 client records, client exit surveys with more than 500 clients, and in-depth interviews with 64 clients and 10 providers. For the purpose of this study, we have defined integration as clients accessing both quality voluntary family planning information and services and cervical cancer screening and preventive therapy services provided by one provider or multiple providers working as a team on the same visit. Next slide, please. So I'm going to walk you through the results. Next slide, please. So 95% of the total participants enrolled to the study were eligible for HPV screening. So among those 914 14 participants who were eligible for HPV screening, 88% received HPV screening and family planning counseling. And 21% of those took up a family planning method. And of the total of those women who took up a family planning method, 20% reported that they had never used family planning method before. So here we have a quote from a participant saying that the services are good together. We come to the hospital on the same day and in the same place. We treat true problems that it's very good. So this is a quote from a client. Next slide, please. So this is the method mix. As we can see, method mix among women screened for HPV who take up family planning methods looks similar to the general population. Short-acting method are most reported uptake method among those screening for HPV. As you can see here, 91% adhere to short-acting methods and 8% to LARC. And we can also see that higher levels of injectables and lower levels of OCs and condoms are seen when compared to the with the 2015 national surveys for this specific age group and within the same geographies. Next slide, please. So with the qualitative approach, we also can see that in-depth interview data suggest overwhelmingly positive experiences with integrated care among clients and providers. So we can see here the quotes from clients and the quotes from providers regarding the positive experience with integrated family planning and cervical cancer screening and preventive therapy. Next slide, please. So we also used data from the study health facility and analyzed the trends of the total women who received VIA and family planning services 3 months prior to the start of the study implementation, and compared it with the total number of women who received integrated family planning and cervical cancer screening and preventive therapy services during the implementation of the study. So we can see here that before the implementation of the peer project in one of the provinces, on average, 9 women per month received integrated services. While during the peer project, the peer study, this increased to 25 per month, with large variations due to COVID and stockouts. Next slide, please. I will not go into all of them, but I would like to highlight some of the limitation and outstanding questions. Part of the limitations include stop and restart due to pandemic and stockouts. So patients were recruited for a cervical cancer project, not family planning research study. So we think that it's likely to have influenced. In terms of outstanding research questions, what does integration look like outside of a pandemic? What does integration look like outside of the constraints of clinical trial? What does it look like when cervical cancer screening and preventive therapy is added to a family planning clinical setting with no recruitment targets for cervical cancer screening and preventive therapy? Next slide, please. So as a conclusion, integration seems to result in increased overall family planning uptake and cervical cancer screening and preventive therapy services uptake. Our results suggest that integration is appealing to both women and providers. Integration of cervical cancer screening with family planning services provision does not seem to have an impact on the overall method mix in the population, at least within these two provinces. The implementation and potential scale-up in Mozambique represents an opportunity to enhance the impact and integration has on uptake of both cervical cancer screening and preventive therapy and family planning services among women. So there is the fact that this can result in increased efficiency in providing access to products and services that improve women's sexual and reproductive health on method mix. Next slide, please. And thank you.
Thank you very much, Marcos. That was really informative and great insights on the integration of those services. And I'm sure folks have questions for you. If you do have questions for Marcos or for Mila, please put them in the Q&A box and we will answer them directly now or during our Q&A portion. Our final speaker this morning is Dr. Eva Lathrop, Global Medical Director at PSI. In her role, Dr. Lathrop oversees a service delivery portfolio that spans more than 30 countries and focuses on sexual and reproductive health, legal abortion and post-abortion care, and cervical cancer. Prior to joining PSI, Dr. Lathrop served as an associate professor of gynecology and obstetrics and global health at Emory University Schools of Medicine and Public Health, and credits her time as a Peace Corps volunteer in Malawi as sparking her combined passion for public health and medicine. Dr. Lathrop will provide more details on the self-sampling component of PSI's work in this study and discuss the practical implications of the study's findings for the field. Over to you, Dr. Lathrop.
Thank you, Heather. Thank you, Tom. Thank you together for inviting us for this webinar. And thank you, Mila and Marcos, for going before me. It's just so fun to hear all of these results from the MULHER study. Again, we miss it. We had a really incredible experience collectively carrying out this study. So thank you again. So today, my role will be to talk about our work addressing facilitators and barriers to self-sampling HPV DNA in Mozambique. Next slide. So we know cervical cancer is a leading cause of cancer death among women worldwide, and that the vast majority of these deaths occur in low and middle income countries. The vast majority are also preventable through the existing screening and precancerous treatment tools that we already have. Mozambique has one of the highest cervical cancer burdens in the world and a severe shortage of healthcare workers and low clinical coverage for cervical cancer screening puts Mozambique in a position to be facing an increase in cases unless strategies to increase prevention are prioritized. Next slide. The Global Cervical Cancer Elimination Strategy has a screening pillar, which states that 70% of women should be screened with a high-performance test by age 35 and again by 45. The current recommendation is that HPV DNA testing is used as the primary screening test for both the general population and women living with HIV. Self-sampling represents a high accuracy approach to HPV DNA testing that allows for privacy and autonomy. And self-sampling for HPV has been shown to be highly acceptable among both women and providers, but barriers remain. So we explored user-driven facilitators and barriers to and provider perspectives on self-sampling using service delivery data and interviews with patients and providers. Next slide. So we conducted a prospective cohort study of women ages 30 to 49. And we did so in 4 public facilities in Maputo City, Maputo Province, and Gaza Province. We also had several mobile units that we worked with as well. Next slide. So overall, our study had several objectives. So the big MULHER study had several objectives. One was to introduce and scale up cervical cancer interventions. Mila talked about this a bit in terms of HPV DNA testing, HPV self-sampling, trying to get to the point where we can have a point of care test using thermoablation and then integrating into family planning services. Another was to assess the acceptability of HPV self-sampling among providers and consumers, to identify effective promotion strategies to increase service uptake, and finally to determine cost of integrated services for cervical cancer and family planning. Next slide. And the focus of this sub-study that I'm talking about today was to assess the acceptability of HPV self-sampling among providers and clients. Next slide. So we approached our question with mixed methods, collecting and analyzing routine service delivery data alongside qualitative, in-depth interviews with women and providers. Eligible women were invited to participate in the study at the time of their clinic visit for cervical cancer screening, for family planning services, for HIV care, or for other reasons. And after we got consent, participants were offered either self-collection or provider collection. Next slide. As Mila said, our total study sample was over 9,000 participants. The median age at enrollment was 37. Over 45% of our participants are women living with HIV, and 31% of our total population tested positive for high-risk HPV. 97.5% of our participants chose to self-sample. Next slide. As I said, we also conducted several qualitative interviews. We had 104 women who participated in the section around self-sampling. With these in-depth interviews, we looked at domains addressing facilitators and barriers to self-sampling. Commonly identified barriers included fears about technique, not being able to understand how to go about collecting the sample, concerns that they may experience discomfort in collecting their own sample versus if a provider sampled, and worry that they would not be trained well enough to correctly perform the sample and get an accurate collection. Next slide. One woman stated, "I worry about self-sampling, if I'm doing it correctly, and also it could be a bit painful." And another person said, "I cannot manage to do the self-sampling. It would be too difficult for me to see my genital organs. I can only do it if I have someone help me collect." But despite these barriers, the vast majority of our total sample chose self-sampling over provider-conducted sampling. Next slide. We also identified enablers per our patient participants for self-sampling. Privacy was identified as one of the drivers for choosing self-sampling, and women who'd been exposed to a peer who had previously self-sampled stated that this gave them the comfort and confidence to choose self-sampling rather than to have a provider collect the swab. Next slide. One woman said, "I like doing the self-sampling for HPV. I did it alone, and I had that experience of evaluating myself. I loved it, and that's why when I explain to the other mamas, I talk about how my experience was. I motivate them and say it doesn't hurt, it's simple and easy. And I say you'll be proud and say that I went to the hospital and did an exam alone to save my life." Next slide. We also interviewed 15 providers with domains examining provider perception of the value of or detraction of integrating self-sampling into their HPV screening approach. We identified both benefits and concerns. Providers identified several benefits, including that the total collection process was faster when women self-sampled than when providers had to do it themselves, and allowed their clinic to move faster. Their perception was that women were happier with a more private option. Providers also felt that there was less equipment necessary for self-sampling, which just simplified their clinic. And finally, that a self-sampling option could allow for systems change to expand HPV testing to outside of facilities and allow for better access and overall coverage. Providers also expressed some concerns, namely that they worried that women who self-sample may not get an adequate sample and may not have an accurate result, and also worried that with the self-sampling and other self-managed care options in reproductive health and elsewhere, the provider role in general may become less and less important. Next slide. One provider said, "Women like to do self-sampling because from the moment that I explain to them how they should do their self-collection, she feels good. And from my experience, I think it's good for women to do the self-collections because they feel good about not being on a bed and saying, position yourself here because you have to spread your legs. It's something that people don't like." Another provider said, "They really fear removing clothes in front of people, so that's why they are more comfortable with this." Next slide. There's so much to say about the entire MULHER study, and this was just one small part of it, but I think we learned a lot. This mixed method study, particularly this sub-study, describes clients' and providers' experiences with HPV self-sampling in order to increase access to cervical cancer screening overall, and expanding the evidence base for HPV self-sampling, as well as contributing to the nascent literature describing prevailing barriers and fears. It also has the potential to advance a more person-centered approach to delivering on cervical cancer screening. Self-sampling promotes equity by increasing control over where, when, and how women choose to be screened. And if it can be scaled, HPV self-sampling holds great promise in improving access to screening overall. Communicating the potential benefits of HPV self-sampling to providers, including bringing awareness of the literature that supports that self-sampling is an efficacious and accurate option, that the results are just as good, would improve acceptance of this approach. And finally, strengthening self-efficacy, bodily awareness, and the sense of agency to self-sample will increase the expansion of HPV self-sampling overall. Next slide. There are so many people to thank, and this is certainly not all of them. Most importantly, to all of our teammates, partners, and participants. Some of those include the University of Texas MD Anderson Cancer Center, Mila, Kathleen, Ellen, and everybody on your team. I don't have Rice University listed here, but I should. We loved working with the Rice team and are just constantly fascinated by the innovation and the engineering and the vision for what can be done and what can be made. MISAO and the Mozambique Ministry of Health, we had so many partners and special people from that group as well. And maybe most importantly, the United States Agency for International Development, who together with the National Academies for Science made it possible for us to do this study. Kevin Piney was on. I hope he's still on. We're thrilled to see you, and we miss working with you. a couple really terrific people we interacted with all the time, Dr. Nafisa and Dr. Ceciltina, both in Mozambique, were just fantastic partners from the PSI team. Heather, you used to be on the PSI team and you started this whole thing with the MDA team. So it just a huge thank you for you. It was hard to certainly step into your shoes, but I was delighted to have that opportunity. Marcos leading us on the evidence and research side, along with Paul Blanchot, who's I don't think is on, but he's another one of our wonderful PSIers, and Hannah Hoover, who picked up after our friend Olga and just did a terrific job. There's many, many other people to thank, but I think I'll end there, Heather. And thanks again to Together for making this possible.
Well, thank you, Eva, and thank you, Marcos and Mila, to everyone for presenting. There's a lot to unpack in terms of the different facets of the overall study, and I would love to pivot now to our Q&A portion of the webinar. If you have a question for anyone, please do share it in the chat, and we will get to it. I guess one of the questions I have to get started is, and Mila, you may be best placed to respond, but feel free for anyone to jump in. I would love to talk a little bit about how you work directly with Mozambican colleagues. Of course, the peer mechanism is about a twinning and development of capacity at the clinical level, at the policy level, understanding that it really is about supporting the systems and the health system to be able to take forward any models and any pieces of this work. Mila, could you talk a little bit about how you all collaborate and how this collaboration has been under the peer project with Mozambican colleagues, and sort of maybe how they're aligning to take any of these pieces of work forward?
Yes, of course. I'm very happy to talk about this. Thank you for the question. I'm sure this was a lovely experience. We really worked hard together with our colleagues from PSI. We could not do this without PSI folks. They were amazing, training all the providers that worked with us. And it was so fantastic to see the progress that they had, the nurses, the doctors, the research team, the lab team, everybody, that we were learning and teaching together, because we all learned during the whole process, and they developed a lot of skills. And now we can say that they are the most experienced nurses and doctors in thermoablation, in self-sampling in country. What is really amazing to see, because now they can help us continue training their colleagues. So with this, we progress the cervical cancer prevention in Mozambique, what is amazing. Of course, we had a lot of challenges. We worked together weekly with these nurses and doctors, training and practicing with images, with all the cases that they needed to discuss with us, and also day by day, 24/7, right, by phone, by other apps that we can to chat and communicate. This was a team effort for sure, and it's really lovely to see the progress for the team there in research, but also in the clinical skills. And now we just continue, because we had a lot of challenges, and we can address these challenges with our new studies that we are launching. And this team will continue together, progressing and developing skills in other colleagues, so we can together help the women in Mozambique. And thank you for the question.
Sure, thank you too. I have a question maybe for all of you, which is to say, you each touched on it in your presentations, of course, but could you all talk a little bit about what it was like to conduct this trial as COVID started to progress and how you were communicating with patients. I know many programs were struggling with even being able to reach patients and to monitor appropriately. How did you all manage to keep sort of everyone tethered to this project as COVID lockdowns and other things were happening? Maybe I'll start with I'm not sure who would like to take the question first, because I don't know who was really on the ground making all of these pieces happen.
I can jump in, Heather, although I certainly wasn't on the ground during COVID, and so maybe I'll pivot to Marcos after that, because you were living it, Marcos. But one of the things we did was talk all the time as a team, as a big team, sort of all partner team, and then a MDA PSI team to try and figure out how when to shut down the study, which and when to sort of for example, when the Ministry of Health went to services are only open for emergencies, or services are only open for certain parts of facilities and hospitals, when did we have to say, you know what, this is a research study and we have to pause, and it's not, it doesn't make ethical sense to try and force this through because we want to enroll in the context of a pandemic. But it was a sort of a living discussion that went all over the place. We don't have to look back at Marcos' graph, but the most complicated graph is sort of over time what our enrollment was like, including that was a graph specifically about people who had integrated services. And you can see how jagged it is because our enrollment varied so much due to the lockdowns and closures and pauses, mostly due to COVID, sometimes due to supply chain issues, but mostly COVID. So I think the key to success for us was communicating constantly, and then having people on the PSI team who were deeply embedded with these facilities and with the Ministry of Health who could manage all of that communication. And then the last thing was your question about participants and how to make sure we were in touch with people if we were getting results at a time when people couldn't come back in for services. We had, maybe this will come up in another question, but we logged a lot of staff hours in making sure that we could keep in touch with clients. It was really challenging, even with sort of unlimited staff hours, to do so. And we did that by phone. So, and that may come up, and there's a question in the Q&A about loss to follow-up and how we kept in touch with people. But that is how we managed through COVID and really through the whole trial. You could pose that that's unrealistic in real life, but that's how we managed in the context of this trial. I hope that helped, Heather. Mila and Marcos, anything to add there?
Marcos, would you like me to go first?
Sure.
Okay, yeah. Thank you, Eva, for the answer, and Heather for the question. It was a hard time that we had during COVID, but I think with the teamwork, it was amazing to see how we could pivot and adapt with everything that happened at that time. As Eva said, we decided as a team, and together with Kevin Payne and all the USAID team, when we should stop the study, when we should stop enrolling, when we should just treat or continue working with the patients and the local team. It was very challenging. And I'll say, starting answering Doug Perrine in the chat, and thank you, Doug, for being here. This was one of the challenges that we lost patients to follow up. And I'll say, when the patients come back very quickly, it's easier, but when it takes a while to call the patients and get them back, it's very hard. And this is what happened during COVID. We just needed to wait a little bit because we needed to stop. All the facilities were only pivot for COVID, and we needed to stop the study. So when these patients were started calling back, it was really hard to get them back. So when it takes a while for us to follow them up, this is the time that we really missed patients and lost to follow up. Marcos, I don't know, you were in country, and of course we had many hours on the phone, on Zoom, continue practicing with our nurses and our doctors there, and just communicating and trying to help as much as we could from here when we could not travel. Marcos, I think you can add here a lot.
Thank you, Eva, and thank you, Mila. I think you have covered it all. I think it was really challenging. Within the 2 years, we are talking about almost 6 to 7 months of lockdown due to COVID. But as you both said, communication and coordination, both within the team and including the client, the communication with the client was really the key for the success that we have achieved. Thank you.
Great, thanks to everyone. I want to continue to unpack a bit around the question in the Q&A box around, do you have thoughts on how to reach HPV positive women who are lost to follow-up and not coming back for treatment? And were there data that specifically looked at lost to follow-up among women who self-sampled? Those may have been presented, and we just didn't catch that.
Mila, do you want to start?
Yeah,
with
of
this one?
course.
And then I just have a comment about how to reach people. Thanks.
Of course. So for these patients, for the HPV positive patients, we actually, it's the great majority of our population. So 97.5%, really the great majority of them. And we tried many times. We say at least 3 times, but actually the phone calls and even sometimes home visits with the mobile unit, as Eva was saying, we tried hard many times. Our goal was 100%, and we said this so many times during our team meetings. Of course, it's very challenging, especially in the places that we had low access during COVID. But we called the patients, the mobile unit went to visit the patients, and we really tried hard with all these patients that were positive. And I'll say that the PSI nurses, they are nonstop. They are really amazing. They did an amazing job with their patients. They were all together with the patients, trying hard to get them back and on the phones, and the whole team of the PSI team was really good. And even our research nurse from Brazil, she helped us trying to get the patients. Our clinical leader, Dr. Nafisa Osman, helped us, and all the doctors there. Everybody called the patients, trying to bring them here back to follow up and treatment. Eva, anything else that I forgot?
No, you didn't forget a thing, but I do have a couple other comments. One question I think you asked, Doug, was if we had any other thoughts about how we reach HPV positive women who aren't coming back for follow-up. One of the things we struggled with was in the proportion of women who we were able to contact and communicate HPV positive results to and set up appointments for, there was a proportion who didn't come back, and we struggled with how often to continue to follow up with that person, those people, that group of people, to say, we really want you to come back to clinic. This is what we would do in clinic. You know, it's not scary. Try to sort of really educate around the importance and how a visit would go. And at some point, we had to develop an algorithm for when we stopped calling, because we were bordering on the verge of badgering people to come back in. So I think there was the group of people that we couldn't get in touch with, which was small. And then there was the group of people we did get in touch with who were HPV positive, who didn't follow up for a variety of reasons. And some of those it was, I'm not going. So I think that the task next is to figure out what's the combination of demand creation, education, and behavior change work for people who've received what are perceived as frightening results, how to motivate and change health-seeking behavior so that people do follow up and are not lost, coupled with making access easier in general. But I think there's a big behavior change piece that we weren't able to address in the context of this study, but I think that we would have to. That's not specific to HPV, but it's one of the things we found. I think we also, it was really would not be possible to scale or replicate the amount of time staff spent trying to locate people and communicate results in a real world setting outside of a clinical trial. And so we talked a lot about some of the digital applications that exist for both results communication and referral setup, and that if we were to expand this outside of the context of this trial, that's something that we'd have to consider, understanding that there would still be a portion of people who would need to have phone follow-up or household follow-up in the absence of the ability to use a digital app. But that's sort of our next phase, was behavior change around seeking care. What are the existing digital tools that might work for the vast majority of people? And then, of course, I'm shouting out again to the RICE team, the point of care test would solve a lot of these problems. I hope that helped, Doug. Thanks.
Thank you. Thanks to everyone for those answers. We have just a few more minutes. I have one question for Marcos in the data that he presented. Marcos, you had shown on one of your slides that prior to COVID, a total of an average of 9 women per month were receiving integrated services, and I think these were women living with HIV. And during the peer study, that average increased to roughly 25 women per month. Do you have insights was that because of increased demand, that more women were coming in because they wanted to access services, or was it really about having increased provider availability, or a combination thereof? I don't know if you have any insights to share with respect to those numbers.
Thank you, Heather. So as I mentioned, we have used the routine data from the dose for health facility, from the register book at the health facility level, accessing the data of the total human who received integrated services via and family planning services 3 months prior to the study, just to compare and have an idea of what is the impact after or during the implementation of the study. But one thing that it's important to mention here is that the data was really, it was challenging due to the poor quality of the data of the registration prior to the study. So that was one of the limitations. That's why we stick to the 3 months period before the study, but the quality of the data was not that much good. So we just took up the total human who received integrated services prior to the peer study and compared to the total human who received integrated family planning and cervical cancer screening during the implementation of the project within those 4 health facilities.
I see. Okay, great. Well, I want to thank everyone again for joining this morning, this afternoon. It's been a pleasure to talk to each of you. If you have any more questions, thoughts, or comments, please don't hesitate to reach out to us at Together for Health. and we will see you next time. Thank you to our presenters, and thanks for everyone for joining. Have a good day.
Thank you, Heather. Thanks, Tom.
you
Thank you,
all.
Heather. Thank you, Tom. Thank you,
Bye,
everyone.
everyone.